let me introduce Farhana. Thank you so much for being here with us. Farhana is an independent consultant who provides strategic planning, technical assistance, implementation support to nonprofits, public agencies, philanthropic organizations on research, evaluation, data collection and management, data visualization, and communications. She previously worked for MDRC, a social policy firm, where she has led evaluations to understand the effects of policies and programs aimed at improving the lives of low-income families, children, and communities. She also developed communication strategies and visual products to educate practitioners and policymakers about evidence-based social programs and policies. Prior to working at MDRC, Farhana was a data journalist for the Washington Post and the New York Times for more than a decade. She oversaw the development of data University's Wagner School of Public Service. Farhana has been working with us since springtime to design the skill builder for you and for this audience today. And we can't say enough about how amazing working with her has been. And we're so pleased to move on to the next presentation. Thank you, Farhana.
Thank you so much, Phoebe. And thank you to the University of Wisconsin team for having me here today. And I also want to echo Dr. Shetty's sentiments of gratitude for all the public health folks who are joining today. Let me just share my screen. Apologies. Can you guys see it? I have two screens, so.
Yep, we can see the slides right now.
Okay, give me 1 second. I'm going to bring it up to my. All right, great. Okay. All right, so let's get started. Evidence communication for effective decision-making in public health. So what is our goal today? Our goal here today is really to try to help all of you who are attending, maybe from public health organizations, practitioners, and their partners, how to make data and evidence more actionable in their work and accessible to communities to drive outcomes. I want to acknowledge that my personal background is not in public health. You all are the experts in public health. A lot of what I'm going to be discussing today comes from research on evidence building and evidence communication that is applicable to public health, including a lot of experiments that were done during the pandemic around messaging of public health, in messaging in public health and what works and what doesn't. I also work with, as Phoebe mentioned, community-based organizations to on capacity building for using and communicating data and evidence. So I want to bring that some of the tips there to this presentation as well. So before we talk about best practices in evidence communication, I want to ground us all in kind of this framework for evidence-based decision-making, which is central to public health. Every day, you guys, agencies, practitioners, you need to think about the evidence that is available to you about what works, what doesn't work, when making decisions about choice of programs and policies, how they should be implemented, how they should be communicated to communities and partners for best results. A core function that public health agencies and practitioners and their community-based partners do for communities is to translate evidence into action, right? So you get research evidence showing that a virus is airborne, you translate that into action for communities. They should socially distance, stay in isolation. Of course, I'm simplifying here, but you get the point. You collect data and feedback showing that there is an increased need for service in a particular area that affects community health. You communicate with collaborators to shape programs and policies. So it's central to your work, as you know. So what do we consider to be evidence? At its core, evidence can be defined as information or facts that are systematically obtained for use in making decisions. I really like this framework drafted by the CDC. This was done for a public health initiative on violence prevention, where evidence is looked at in a holistic way for decision making. It's not just about research evidence, like trials that look at effectiveness of interventions, which of course are very, very important to public health, but it's also looking at contextual and experiential evidence, right? What do we know about the collective experience and expertise of those who have practiced or lived in a particular setting? What can the experiences and knowledge of partners and community members tell us about what has previously worked or not worked within a specific community or a population in question? Do the strengths documented in the research evidence match well with the needs of the community? Does the community have resources or capacity to implement a prevention strategy, for example, effectively? And what adaptations might need to happen? All of that, the experiential and contextual evidence need to be combined with research evidence to come to evidence-based decisions, right? So in public health, data sources for evidence-based decision-making can include a combination of quantitative and qualitative data. You have, of course, you have epidemiological surveillance data, you have community surveys, needs assessments, systematic information collected through interviews or focus groups with community members. So all of this is evidence in public health, and they all serve different purposes. And this is the last of the stage setting that I'm going to do, but it's a very simplified slide that shows you a depiction of evidence communication in public health. There's increasing understanding that promoting health and protecting communities require both sound evidence and effective communication, right? Data or evidence doesn't speak for itself. It needs to be put in the hands of the general public, communities, and decision makers in ways that can drive actions for good public health outcomes. So we have local health departments, health systems, CBOs, and people who work at these organizations, have many different audiences that they need to discuss and share evidence with, to educate about interventions, to build partnerships, to shape programs and policies, to drive funding, to drive behaviors and practices. And this communication takes place through multiple modalities, right? So media campaigns that target broad swaths of population, to one-on-one communication in a clinical setting with the patient. So think about all the different ways in which you've had to think about communicating about, I'm going to just use COVID transmission or vaccination as new data and evidence emerge, right? So evidence communication, the point that I want to make here is not just the job of the people who work in communication roles in public health departments or organizations. It's just part of most jobs in public health: community health workers, scientists, nurses, clinicians, managers, administrators. I mean, the examples on the list, this slide, are by no means a full list, but the point I'm trying to make is that everyone has a role in evidence communication. And health departments and organizations have to build the capacity for evidence communication internally so that it's actionable and accessible to workers in different roles, and then also community members. So I want to start with, the best practices for external communication, and then circle back to what that means for capacity building within health agencies, and what it means for internal evidence sharing that can drive optimal external communication. I speak really fast, so please use the chat function if you have any questions. I know the University of Wisconsin team is monitoring the chat, so if there are any questions, I can take them along the way, because it's a long presentation. So, you don't need to, we can kind of engage with each other along the way. And there's one question I did want to ask you, and as I'm presenting, please feel free to put stuff in the chat, like how you currently communicate with evidence in your day-to-day work. All right. We'll pause for a couple of seconds to see if we get anything. Yeah. So I'm going to keep going, and then we can come back to see if we get any answers on the chat. If that's okay, Mackenzie. Okay,
Yeah,
so
that's
what
okay.
do, yeah, great. So what do we know about effective evidence communication in public health? So as I said, a lot of this is drawn from that research that was done in the US and other countries during the pandemic, right? About evidence communication and messaging and what works and what doesn't, right? So what we've learned is that when translating evidence into action, folks need to balance the goals to inform and educate with the goals to persuade and prompt. The research shows that people are very sensitive to perceived goals of communicators. So we've learned that if you're perceived to be prioritizing persuasion in public health communication, that is, if you come off as trying to get people to change their beliefs or behavior by quote unquote selling the science, you may risk losing trust. So in general, and I'm generalizing here broadly, much of the health communication during the pandemic was designed to persuade people with messages like masks save lives. They're intended to like compel people to wear a face mask, right? So we wanted to persuade people to follow recommended or mandated control measures, but there wasn't always we didn't always directly share the evidence or information that would enable them to make an informed decision or understand at least the justification for a mandate. Again, I'm generalizing here, not saying everybody did that, but that was just the general landscape. Often the argument made is that people can't take in a lot of data or information at once, and simplified messages are best. But we found that messages designed to persuade without components of education can limit people's ability to make informed choices, and can negatively affect their trust in experts, which in turn can negatively impact compliance, right? And then balancing risks versus benefit, like that's really important, to provide people with as balanced a picture as possible about the benefits and risks of interventions, policies, and programs so that they can be compared fairly. Partial presentation of evidence like downplaying or uncertainty about the risk of side effects of an intervention does often occur in public health messaging. However, in this example, if side effects are discovered over time or new research shows some sort of harm to a specific slice of the population in any way, it could undermine trust for any future communication. So as soon as we are perceived to be ignoring or underplaying something our audience considers important, the motivations for communication and trustworthiness are questioned. And the balance between credible knowledge and uncertainty and contradictions. Uncertainty is inherent in public health, right, and healthcare evidence. During the pandemic, as with other public health emergencies, we were essentially co-producing response and evidence at the same time, right? New evidence emerged every day. There's a lot that we didn't know at any given time. When we don't know something, or if evidence isn't clear about a particular topic, then it's important to be transparent about it and discuss what it means for the way decisions should be made, in light of limitations of what can be known. So, the challenge is often we tend to underestimate the sophistication of our audience's sensitivity to cues of quality, like knowledge, credibility of the evidence and confidence in data and evidence. But in experiments during the pandemic, sharing the quality of the evidence, for example, saying something was of a small sample, so, or it wasn't, something wasn't tested with a particular population, so the evidence are not conclusive about that effects on that population, or sharing unknowns that we just don't know about something, it didn't undermine trustworthiness of a message. We've also learned that people's reactions to public health communication really depend on their perception about whether they are being presented with high or low quality information. So, the summary with all of this is the lessons that it's really important to actively communicate with people the data and that evidence that is behind public health recommendations. It's more effective to help people to make informed choices and to educate even when mandates are involved, right? The aim should be to clearly communicate data and evidence along with a set of actions that is supported by the evidence. It's important to highlight individual agency and social responsibility so that individuals feel empowered to take those actions with the materials that you're using to educate. There is concrete evidence that passive sharing of information, like putting data on a website or putting a report on a website, is not enough to translate to action, and that active modes of engagement, and that's often, listening sessions like one-on-one, or just translation of data in more active way is necessary, along with products that are accessible. So it's important to present a balanced picture by communicating risks and uncertainties, right? So communicators can combine both what they know, like, okay, these are the facts, and what is not known, right? So someone might say in a clinical setting, while there's been a lot of research about this question, the answer still is not clear. Let me explain my view of the dilemma, right? So just being clear with communities or individuals about what is not known. This reinforces their position, the position of public health communicators as trusted, credible messengers who are authentic, and they're trying to meet people where they are. It's also important to provide concrete examples and tangible metrics to help people understand, health evidence and related actions. So, and to make it to help them digest data, right? So, for example, instead of saying, the booster shot is 90% effective, right? It was found to be more effective to say 9 out of 10 people who got a booster shot did not have to go to the hospital after getting infected, right? So it's providing the metric in a way that makes comparison or perceiving the number to be like 9 out of 10 people, right? It's more understandable, it's more comprehensible to folks. Stressing trends and patterns in a localized way is also beneficial. For example, instead of saying across nearly 250 million patients studied, the risk of developing a condition due to the vaccine is like 0.002%, right? That sounds very scientific and it's scientific, correct. But what was more effective is to say, if the entire city of Houston got vaccinated, about 40 to 90 people in the entire city may get this complication. So again, localizing the data, putting it in the local context, appeared to be more beneficial in public health data communication. And last but not least, and we just spent, Dr. Sethi's presentation was about, we need to anticipate misinformation, right? I'm not going to spend too much time on it because we already talked a lot about it, but research on climate change, COVID-19, and other topics show that if people are preemptively warned against attempt to sow doubt, they tend to resist being swayed by misinformation or disinformation, right? So in public health communication, this requires anticipating potential misunderstandings on disinformation attacks, right? And understanding the concerns of the audience, like reading public forums, social media sites, popular news sources, like consider what decisions your audience are making and what information and in what format, like they're getting this information, and how you can debunk or pre-bunk that, right? And so that needs to be kind of a, not an afterthought, the misinformation, disinformation piece, but, it has to be kind of a at this day and age, like need to anticipate that it's going to happen. Any questions so far before I go on? No? Okay. All right. So what else have we learned from research, from the pandemic research? The lessons on this slide are essentially tied to making evidence communication equitable, right? And we saw the extreme need for that during pandemic. As you all know, access to health and access to information are greatly vary by racial, ethnic, and cultural groups by geography, by physical and cognitive abilities or disabilities. So the pandemic highlighted that our approach to communication, right, really needs to be embedded in concerns and living context of different groups. I'll use an example from New York City where I live. You know, the evidence tells us that physical distancing can limit the chances of getting the COVID-19 virus, right? So in the early months when the city was hit like severely by the pandemic, in 2020, the messaging around quarantining or physical distancing often didn't take into account like the living conditions for low income or immigrant communities like mine, where you have multi-generational households and like single small apartments, right? It was impossible for people to just put in, you know, someone who was infected with the virus into a whole separate room and shut the door, which was often what the messaging talked about, right? We like needed to adapt the evidence or recommendations to people's actual living conditions. And all the literature from the pandemic points to that need as well, right? We needed to adapt communication for people who were facing economic and social challenges about their ability to stay home if feeling ill or isolate from their families. So those, you know, obviously we know what to do, we need to do from a health standpoint, but from a public health standpoint, all of these other factors in messaging play a big role. When communicating about different groups, we also need to be cautious about potentially stigmatizing them and, you know, challenge narratives about their behavior. So the pandemic highlighted the need to enlist diverse tools, messengers, community partners in evidence communication. What was found to be successful was rooted in finding community champions or trusted messengers. That includes advocates, faith leaders, community leaders who speak the same languages, understand the cultural nuances, and work with community members to help raise awareness at a grassroots level, right? Having tools available in different languages, making use of publications, radio or television channels, or other media outlets that specifically serve certain geographies or racial ethnic communities, right? Having listening session, meeting people in the spaces where they naturally congregate and feel comfortable in communities. Making use of different types of tool on social media, right? Visuals, memes, videos, stories. So, you know, it was really meeting people where they are, and that required a lot of different modes, a lot of different messengers, and that is all tied to equity, because that's about reaching all the different groups that we need to reach, right, in a culturally sensitive way. So I do want to use an example. For example, I'll use vaccination among African Americans as an example of what I'm talking about, right? So especially around the stigma piece, right? So the prevailing narrative around lower rates of vaccination in Black communities has been and was like vaccine hesitancy. You know, there's institutional mistrust, which there is evidence of, and in many ways it's justified, right, due to the historical experiences with racism in healthcare and medical research. But we now have research showing that, you know, vaccine hesitancy decreased more rapidly among Black individuals than among white individuals since the early days of the pandemic. And the research finds that the likeliest cause of that is the purposeful efforts of Black leaders and community educators who have been proactive about sharing the potential for community impact of vaccines for Black people, right? So at least in Black communities, vaccine mistrust that was grounded in community experience of racism, right? That mistrust wasn't resistant to that wasn't resistance to protective health behavior, but rather a commitment to protective health behavior, the initial mistrust, right? But that mistrust then it was channeled by community leaders to change minds about vaccines by communicating about their safety, et cetera, right? In this context, right, the lower vaccine rates among Black individuals, which persist, right, when compared to white individual, is likely not vaccine hesitancy, which was a prevailing media narrative and something that is stigmatizing, but it's likely access to, you know, contemporary inequities around medicine and social determinants of health, which is where the focus should be not just battling mistrust, it's about access too. So the importance of educating and staying informed about the historical, cultural, and policy context of the communities we serve needs to be highlighted, and ensure that the messages and the messengers reflect that context. I have a mini break scheduled here to answer any questions. I mean, you can chat or you can raise hands. I'm going to pause for a few seconds to see if there are any questions or anybody want to ask anything about what's been presented so far. You guys are quiet today. Okay. So as we are talking about equity, I want to kind of share 10 considerations for equitable communication, which, you know, considering equity is obviously part of effective health communication. You know, so as you're thinking about how to communicate, whether one-on-one or more large scale wholesale communication, right? Designing some, you know, campaigns or designing products for communication to different audiences. There are some considerations that I would love for you to keep in mind, right? Like, can all those who can benefit from the communication understand it and access it, right? Where is tailoring necessary to reach different groups? Is tailoring necessary to reach different groups? What contextual information may inform how the audiences access, understand, receive, and use the information? Like, what about the context of a specific groups or a specific population that you may need to use in your communication to help them access, receive, and understand what you're saying? Have we engaged with the community to ensure that our communications respect and respond to their cultural and linguistic preferences and diversity? How can we stay meaningfully engaged with community members to remain current and relevant based on changing context and preferences, right? So number 3 and 4 here is really highlighting the need to, like, whenever possible, designing communication around public health with community members, with community leaders, with community-based partners, with population-specific experts, right? So really highlighting the collaboration with the community piece. But it's also needs to be a number 4 is different than number 3 in that it's not a one-time engagement thing, right? It's a continuous engagement piece, right? Like the context changes. Preferences of people change, and we saw that during the pandemic. The context changed from month to month, from year to year. How do you adapt your messaging? How do you adapt your communication to align with the evolution of the context and preferences? Number 5 is what assets, strengths, or successes of the community can we include or highlight? Like, are we creating any harm or perpetuating in the stereotypes? So real importance of strength-based messaging, right? Are communications available in the languages primarily spoken by the intended audiences, right? And is there clarity and cultural relevance in how we are translating public health concept, phrases, metaphors, and analogies? Number 7, are the words, images reflective and inclusive of intended audiences? Are they accessible to the audience? So they're like, you know, have we considered how individual with different age, different cognitive or physical disabilities, or gender, sexual orientation, socioeconomic status, you know, racial and ethnic identities, just to name a few, how will people with different characteristics might respond to the images and languages we use? That's something to really keep in mind when designing public health communication. Are they accessible to the audience, right? So one example, for example, about 15% of the population have some form of color vision deficiency. So that's color blindness, in other words. So, you know, the most common form of that, they can't distinguish between red and green or blue and yellow, right? So, but, you know, just thinking about the different groups, and when you're designing products, or when you're designing, you know, visuals, like, you know, is it actually accessible? Can people read? It's not just about like accessible in terms of can they comprehend it, but can they actually access it? How will they access or consume this information? Like, is it online, phone, in person? So the modality needs to align with, you know, your goals, and your products need to align with the modality. Like, are there barriers to digital or in-person access, as you're designing communications for different people? Can the intended audience easily locate the resources or communications, right? Like, are they available in multiple modes or channels? Can they easily understand the key takeaways, action items, and technical concepts? So all of these things, you know, there are many more, but just, you know, I'm highlighting some like 10 questions that folks can be asking themselves when they are thinking about effective communication, whether one-on-one or whether through large-scale campaigns or in other modes, listening sessions, about how to make their communication more equitable. I'll pause again to see if there are any questions. Okay. So, you know, we've said a lot, right? How about what effective communication could look right? But, you know, we can't. Now I kind of want to talk about how do we build the necessary capacity for effective evidence communication. There are many barriers, and a lot, you know, you guys have experiences with this. And if, you know, as I'm going through this slide, please, you know, if you want to in the chat, you know, share what barriers you face with to communicating with evidence in your specific work. There are people of different roles who are participating in this immersion. So would love to hear from people, like from their role, from their context, like what barriers they face to evidence communication or communicating with evidence in the work that they do. You know, the first barrier is a lack of applicable and actionable evidence or data. Like, first, you have to have evidence that is applicable to your context to use it, right? So, for example, if you're serving a community that's primarily Indigenous or Asian, for example, this is just example, and research and data collection has not prioritized those populations in the United States, as has been the case historically and to this date, then what data or evidence can practitioners use, right? Like, often the data that is collected or the research conducted does not answer the questions that are highly relevant to the practitioners and that can help them prioritize decisions around how they approach their work in those communities. And then there are capacity constraints, which is what I'm going to talk about more here. There are resources, staffing, infrastructure, you know, cultural practices of public health organizations and their partners. So there can be organizational barriers as well to evidence communication. Other core barriers are, you know, silos among organizations and systems that affect public health, right? So that, you know, includes lack of data sharing or approaching policies or programs in a cross-cutting way. And last but certainly not least, everything is shaped by the political and funding and regulatory context that affect your work, which someone brought up when Dr. Shetty was presenting his slides. So I wanted to acknowledge all of that, right? The lack of existence of evidence that might be applicable, the system silos, the fragmentation often that we experience when we work in public health. And then the context around politics, right? There's you know, politicians sow mistrust in public health research, so that's unavoidable. There's you know, funding is always limited to the scope of the need that is in communities. So, but I wanted to acknowledge that, but today I'm mostly going to focus on the kind of what can be within the control of many of you who are participating today around organizational capacity. As I said, if you guys want to share some of the barriers that you face to communicating with evidence in your work, we would love to hear it. Please feel free to share in the chat or raise your hand and we can get to you soon after. So this slide is, this is a very, very simplified snapshot, and it's an example of the way the evidence building and communication cycle can be very linear, right? And often does not involve input from communities or practitioners or frontline workers, right? So you have, I would also love to hear to see if this kind of matches your experience. So you often have public and private funders, like that's often the government's the funder, right? Or there are private funders as well. You have researchers, scientists, and who often make decisions on what questions to answer, what data to collect, et cetera. And then the evidence is often handed over to frontline workers or communities in the form of data sets and dense reports that exist on websites. Again, I'm broadly generalizing, not saying that happens all the time or everywhere, but generally this is the status. Frontline workers also often collect data from like patients or community members in their work, but are not often consulted always on how data collection instruments or systems are designed or how the evidence is interpreted, right? I'm simplifying here, but unfortunately it's the prevailing way of evidence building communication in the social sector. And then there are intermediaries like journalists or influencers who often translate evidence for communities. And it's a kind of a more top-down thing that happens. And what we want is more of a cycle where practitioners and communities are involved in key aspects of evidence building and communication, right? So, we want to foster equitable collaboration between researchers, administrators, communication professionals, practitioners, and communities that to make evidence actionable. What I'm trying to say is all of those best practices that I've shared with you in the previous slides around how to communicate with communities effectively can't really happen unless, we make our evidence, the way we build evidence, more equitable, right? So, and we actually produce evidence that is actionable for practitioners and communities. So making sure that the questions that we're asking, the questions that are driving data collection efforts, reflects the need for knowledge in those local communities, and that the target outcomes are meaningful for those communities. Recognizing the value of practitioner expertise and lived experiences of community members when we are designing data collection and analysis plans to collect evidence. Understanding the need for differentiation of products, right, or strategies to communicate evidence in ways that are relevant for their use. Identifying ways to ensure that communication of evidence is accessible to those who are most affected by them. So the evidence cycle needs to be such that it engages practitioners and communities in various stages of the process. And so what can public health organizations and other organizations who work in public health how can they build capacity to communicate with evidence? So a key thing is to build an organizational culture around learning and improvement with evidence, right? So that involves, there needs to be leadership commitment to evidence-based decision-making, like leading by example to move beyond simply using data and evidence for compliance to using them for learning, improvement, and communication. I wanna really stress the culture component of working with data and evidence that we've found to be crucial. Turn the collection, use, and learning from evidence into a systematic process, right? So using learning agendas that are cross-organizational, creating spaces and opportunities for dialogue, reflection, and learning from data and evidence within organization and across partners. you know, reviewing and improving your data and evidence practices regularly, like, you know, by evaluating their effectiveness, right? So how do you use in data that you have, how do you use evidence that you have to actually make decision? Does it get used? And if not, why not? Like, so really making evidence a part of the way you think about decision making, because communication comes after, right? As I was saying, the internal communication and sharing of evidence is crucial to making sure that workers at all levels, practitioners at all levels, partners, that there's alignment around how evidence should be interpreted and used and communicated to communities. So building that culture internally is really crucial. You know, when instances where evidence is insufficient, engaging, you know, staff and improving the availability and quality of evidence. So again, collaboration internally among different roles, scientists, administrators, community health workers, practitioners who work with frontline practitioners, to in all aspects of evidence building, to create a culture where to create a culture where effective external evidence communication can actually happen. And obviously you need talent training and tools, you know, offering tools, frameworks, training and coaching to build capacity to translate evidence into action. Not all of us have the same level of data literacy. Not all of us know what different research studies, like the methodologies, not all of us are, you know, that because we all have different expertise, different experiences. So people need the resources, people need the tools to be able to use evidence in their work and to communicate it with the general public, right? So that also requires investing in products and tools that enhance the accessibility of data and evidence, dashboards, presentations, visuals, like action playbooks for implementation. That also requires explaining like technical terms in plain language. And I know you guys did a session on using plain language in communication earlier here, so that, you know, practitioners and community members have a clear understanding of the methods, analysis, and limitation. Yeah, I wanna, this was my last slide. I really wanna highlight this piece before I end my presentation, like centering on the needs of both the communities and the practitioners who interface with the communities when we're planning, building, and sharing evidence is crucial to actually making public health communication more effective on the ground. So we have to start thinking about how we like where we're building evidence, how we're collecting data, all of that ultimately will feed into the messaging that is available to communities to make decisions with. So I'm going to end there and move to questions and discussion if there are any.